Hi, everyone. Welcome to the SAEM Research Learning Series course online lecture titled Learning from the Past, Rigorous Retrospective Studies. And now it is my pleasure to introduce to you Dr. Bryn Mumma. Dr. Mumma is an associate professor at the UC Davis Department of Emergency Medicine. Her research training includes an MAS in clinical research, as well as K-12 and K-08 career development awards. Her research focuses broadly on cardiovascular emergencies. She is the vice chair of the SAEM Grants Committee and also serves on the SAEM Research and Bylaws Committees. She has been recognized with Young Investigator Awards from the Society for Academic Emergency Medicine and the American Heart Association. Dr. Mumma, I will now turn it over to you.
Thank you. I appreciate that. It's a pleasure to be here today. I'm going to talk about learning from the past, rigorous retrospective studies. We're going to talk today about how to do a good chart review study. Before we get started, I have no disclosures. Our objectives for this seminar are really to understand the advantages and disadvantages of chart review projects, and then to understand the critical steps in conducting chart review, either for quality improvement or for research. And I want to emphasize throughout the talk that I'm using the term chart review to include any data that is directly exported from the EMR, usually by an IT analyst, and data that's manually abstracted by the EMR in more traditional chart review format. So what is chart review? Quite simply, it's the use of pre-recorded patient data from medical records to answer a QI or a research question. We're lucky now in that we don't have to filter through paper charts, but certainly filtering through the electronic charts can be just as much of a challenge. So let's talk about how to tackle that challenge. Why is this important? So many residents, fellows, and faculty rely on chart review studies to meet program requirements and to obtain preliminary data for grants and research studies. Chart reviews comprise about 25% of the emergency medicine literature and about 53% of the emergency medical services, the EMS literature. So you will encounter these studies in your career. As a practicing clinician, it's important to understand how to interpret these studies and apply them to your clinical practice. As a peer reviewer for a journal, you need to understand how to critique these studies. And certainly as a principal investigator or as a mentor, you need to understand how to design and conduct these studies. Chart review has many advantages. That's why it's so frequently used. First, it's relatively inexpensive. You don't have to pay someone to screen 24/7 in your emergency department to enroll eligible patients. It also requires less time to complete than prospective studies. So for example, if you need 5 years worth of data, you'd have to enroll prospectively for 5 years, whereas you can have 5 years of retrospective data almost immediately from a chart review study. This makes chart review feasible on the shorter timelines, often 1 to 2 years, that residents and fellows have for completing their research project. Chart review also allows for the study of rare diseases and harmful exposures. It's particularly helpful in situations where it would be unethical to randomize patients to conditions such as toxic overdoses, envenomations, or environmental exposures. Last, but certainly not least, chart review studies usually qualify for an expedited IRB review process. At my institution, a chart review study can usually be approved within days to weeks, compared to weeks to months, or sometimes even longer, even for a prospective observational study, sometimes even longer for a clinical trial. But as with any study design, chart review certainly has its disadvantages. One important disadvantage is that the investigator has no control over the assessment of the exposures or the outcomes. As an investigator, you're really depending on the clinical documentation to be accurate and complete. However, we all know that that unfortunately is not always the case. Our charts contain missing, conflicting, or even incorrect documentation. I think we've all seen this. We've all seen conflicting information when we compare the notes from the triage note to the ED resident, to the ED attending, and then even to our consultant and the admitting team. Each of us gets a slightly different history from the patient and documents something slightly different in the chart. Studies have also shown that approximately 1/4 of the care recorded is not actually provided, and the care provided is not documented. So it really goes in both directions. Finally, certain symptoms, exam findings, or results may be minimized or not documented at all, particularly when the charting is completed at the end of the encounter, where the diagnosis is known, and we kind of pull out the most relevant pieces to tell a clear, logical story at the end of the encounter. Taken together, all of these items place chart reviews at risk of bias. This study shows just one example of symptoms not being documented. So in this study, researchers interviewed 215 patients with acute myocardial infarction and compared patient-reported symptoms from the interview to those documented in the medical record. Chest pain was well documented in the medical record. As you see here, 89% of patients reported it, 86.6% of the time it was in the medical record. But we see really large discrepancies in other symptoms, particularly fatigue, 65% reported by the patient, only 4% documented in the medical record. And weakness, again, 64% reported by patients, just under 8% documented in the medical record. So we'll talk a little bit more about kappa statistics later, but these kappa statistics of 0.002 for fatigue and 0.071 for weakness certainly do not indicate good agreement between the patient report and the medical record. I mentioned earlier the risk of bias, and this is a really important limitation of chart review studies. We can think of a chart review project as kind of looking back through a series of lenses, such as in a telescope, or in this study coined by Kaji et al., a retrospectoscope. So our goal with chart review is to really look straight back through the lenses so that our study results perfectly match the true effect in the target population, shown here with the green line. However, we risk introducing bias at kind of each step in the chart review process or each lens in the chart review process. Looking at the red line, you can see how a small amount of bias or refractive error at each step can substantially change the study's results and lead to the investigator to really completely miss their target or completely miss the true result. So what can we do to conduct high quality chart reviews and make sure we hit our target? We can and we should start by asking appropriate questions, plan carefully, including case selection criteria, variable definitions, a coding guide, and data collection forms. We should carefully think about when we're going to use directly exported data or automated data abstraction versus manual data abstraction. And then finally, we need to review and validate our data very carefully. So the first step, as I mentioned, is to ask appropriate research questions. Some questions simply can't be answered via chart review. The charts available for review first must represent the population of interest. For example, if I want to study all patients with out-of-hospital cardiac arrest, but only have access to hospital discharge records, my study population will miss all the patients who only received pre-hospital care, who perhaps had pre-hospital termination of the resuscitative efforts, or maybe even who died in the emergency department, and they really won't represent all patients with out-of-hospital cardiac arrest. Or let's say I want to identify triggers of asthma attacks in patients who present to the ED. And let's say my emergency department has such a high volume of asthma patients that I realize I really only need to include 3 months of data. However, if asthma triggers vary seasonally, I might pick 3 months during the winter season and conclude that most asthma attacks are triggered by influenza or other viruses. And I might miss attacks that are triggered by pollen or wildfires during other times of the year. As an aside, if you do encounter this where reviewing an entire year of data would be too onerous, you can just randomly select a sample of charts from a 1-year period to avoid that seasonal bias. You also need to consider external validity, which may be compromised if charts were taken from a setting with an atypical population or practice style. So this is just something really important to consider when you think about whether your single site study can really answer the question that you want it to answer. Because data in the charts were not recorded for the purpose of your research study, you need to be certain that the charts contain the documentation of pertinent items. For example, let's say I want to evaluate the association between diet and constipation related visits in a pediatric ED. Because detailed information about patients' diets is typically not collected during most ED visits, I probably wouldn't be able to answer my study using chart review. Instead, I might need to prospectively enroll patients, ask them some questions, administer a survey while they're in the emergency department. Similarly, let's say I need to calculate a Wells score for PE. One element of the Wells score is that PE is the #1 diagnosis or equally likely diagnosis. In my department, many of our physicians have a template for their differential diagnosis for chest pain and shortness of breath. So unless a physician clearly ranks his or her differential in the notes, it's really hard to determine what they consider to be most likely, and thus to accurately calculate a Wells score. I encountered this in one of my own studies, and we sort of worked around it. Our solution was to use the Geneva score instead of the Wells score because it avoids this criterion. Finally, you need to make sure that the available number of charts provides an adequate sample size. A full discussion of sample size calculation is really beyond the scope of this lecture. That's another topic in and of itself. But there are several statistical programs and online tools that can assist you with sample size calculations. If your initial sample size will not provide adequate power, consider adding additional years or using additional sites, whether that is additional hospitals, additional EMS agencies, whatever it takes to get to the sample size you need. So it's really important to think about this up front rather than waiting until you get to the end when you're starting your analysis to realize that you don't have enough patients. As I mentioned earlier, really, really important to plan carefully. There's always a balance between the time required to abstract data against the benefit of having more data. In general, I err on the side of including variables. For the most part, it's easier to collect a few variables that you ultimately don't need than it is to re-review all of your charts to gather additional information. At the same time, when you're planning your study, you want to make sure that you can justify each variable you're collecting. Think about the analyses you'll want to include in your and the data you'll want to include in each of your tables, and then make sure you're collecting those data. Finally, whenever possible, have your data automatically abstracted from the EMR. Even if you can only have half of your data automatically abstracted, it will save you so much time in the chart review process. And if you're using a data management program such as REDCap, which I highly recommend, and we'll show you a few screenshots from in the coming slides, you can import the data that have been directly exported into REDCap and then use REDCap to collect the manually abstracted data as well. You want to carefully define your inclusion and exclusion criteria a priori. You have a lot of options for how to identify your cases. Some commonly used things might be chief complaints, diagnosis codes, receipt of a certain medication, or undergoing a specific procedure. In general, you want to ensure that all eligible charts are captured, and this typically requires using multiple methods. So for an example of a case of a study that I did, I was trying to identify cardiac arrest patients. So we might use a diagnosis code, an ICD-9 or ICD-10 diagnosis code, a CPR procedure code, a chief complaint of CPR, or a patient who received epinephrine 1 milligram IV push, because we felt like there were really no situations outside of cardiac arrest where that specific drug would be given. Once you've carefully defined your study inclusion criteria, the next step is to start defining your variables. And you really have to put a lot of thought into how you define your variables early in your study. Something even as seemingly straightforward as fever can be defined in many different ways. So if you want to collect data on whether fever was present, you need to decide whether you want fever to be measured subjectively or objectively, at home or in the emergency department, and what your specific temperature cut point is going to be. And this may vary by study in terms of what cut point is most appropriate. You'll also want to determine, as I mentioned before, whether you can directly export data from the EMR versus when manual abstraction is required. Two broad reasons to use manual abstraction over direct export would be, first of all, the data may not be available as discrete entries in EMR. Instead, the data that you want may exist in text fields or even in another system. At my hospital, we encounter this with our electrocardiogram or ECG reports and our radiographic interpretations. So for those, we can export the entire interpretation, but we can't directly export, did the patient have a PE, yes or no, or did the chest x-ray show pneumonia, yes or no, as a discrete variable. The other time where you may want to consider manual abstraction is when the data that you're trying to abstract requires some synthesis or interpretation from a reviewer. For example, if you're trying to figure out the rationale for ordering a test or the circumstances surrounding an event, that is something that's typically going to require manual chart review, having a person read multiple notes and put that information together to get the data you need. Regardless of which approach you choose, you want to perform a full manual chart review for a subset of charts that represent a variety of patients in your study to validate that the data that were directly exported are correct. You also want to determine from the outset how missing, ambiguous, or conflicting data will be handled. We talked earlier about the differences between the triage note and the ED physician note and the admission notes. Typically, you'll want to have a hierarchy for what you'll use, which one will take priority when there's conflicting data. For example, will you use the chief complaint from the triage note or the ED physician note? When triage vitals are incomplete, will you use the next recorded value or consider it missing? Neither is right or wrong. It really depends on your study, what makes the most sense, and what will introduce the least amount of bias into the study. It's also really important to write out a coding guide for your abstractors, whether it's a manual abstractor or your IT analyst, that really defines the variables and instructs them where in the chart you want them to find the information. This is an example of a standardized form. This is a screenshot from a study that I did in REDCap. So the variables are clearly defined, not only in a data dictionary, but also here on the data collection form, so that the abstractors can easily reference them as they're going through charts. You'll notice that I put my no's and yeses in the same order rather than yes, no, no, yes for subsequent questions. And you can see here that I clearly define variables. So any DBT or PE present on admission, any documented DBT above the CAF popliteal or above, or any PE on admission. And the same for the next two questions. Acute renal failure is very clearly defined rather than just leaving it up to the abstractor to decide what they consider to be acute renal failure. Here's an example of how those same variables might be defined for automated extraction. When defining these variables, it's really important to think about how data are entered and stored in the EMR. If the concept you want is not directly recorded in EMR, you may be able to identify a surrogate marker or a timestamp that does exist in EMR. So for example, if you're looking for a DBT or PE present on admission, you might use commonly used code ICD-10 codes for DBT and PE with a present on admission modifier. Similarly, for acute renal failure, you might want to use the ICD-10 code for acute renal failure with the present on admission modifier. In this case, I think this is where manual validation would be really important, because you would want to carefully validate to make sure that these codes are capturing all cases. For acute renal failure, for example, you may also want to record the creatinine value. It's really, it requires some more data curation to compare the current value to the baseline creatinine value. But again, that's something that might be possible or might require sort of a hybrid approach where when the creatinine is elevated, you manually review those charts to see if it was an acute kidney injury or whether it's chronic kidney failure. These are things that, we do intuitively when we review charts, but a computer will not unless you really tell it what you need to be done. Finally, you'll want to create a coding guide, again, either for your abstractor or for your IT analyst to make sure they're looking in the proper place. And here's just an example of a coding guide with the list of variables we wanted, where to find them in the electronic medical record. Because if your EMR is anything like ours, there are a lot of different places where the same data could be recorded. We talked about data collection forms. Here is another example of a data collection form. Once it's created, it's really important to pilot test the data collection form. So this was an example. We were trying to find the electrocardiogram reportings. And here's an example of a data field that we revised in response to initial abstractor questions. So when we initially created this data collection form, we only had sinus rhythm and atrial fibrillation or atrial flutter. But as we got into the chart review, we found that this was a study of patients coming in with suspected acute coronary syndrome. We found that a lot of them had a pacer and therefore had a ventricular pace rhythm. So we added that as an option for the initial rhythm on the ECG. In general, you want your data collection form to follow the flow of the chart. So begin with the chief complaint, begin with the HPI elements, and then group all the laboratory data together, all the radiology data together, et cetera. So your abstractors aren't jumping back and forth between different pieces in the chart. And as I mentioned before, you want to follow the same pattern for similar questions. So yes first, no second, no first, yes second, but follow the same pattern for all the questions, particularly when they're listed right in a row like this. If possible, I would recommend using a computer program such as REDCap that allows for real-time error checking and data validation. You can do this in Excel, but I don't recommend using Excel for your primary data collection. There are just some other errors with Excel. It's very easy to sort and shuffle your data, so I do not recommend Excel for your data collection. You can also enter hard stops in the data collection form for required data fields and warnings or soft stops for non-required fields, in which the abstractor will get a flag if they accidentally skip a field. It's a nice mechanism for sort of alerting the reviewer while they're in the chart to just get that data element. You can also set data validation as shown here. So this was an example of the data validation we suggested for a study of adult patients. You might require an integer between 18 and 115 in the age field in a study of adult patients. So this is an easy way to make sure someone doesn't accidentally enter 8 instead of 80 for a patient's age. Similarly, for directly exported data, you'll want to identify any sort of nonsensical values or outlying data points and have a plan for addressing them. This could be manual chart review, or it could be just simply creating a rule that replaces nonsensical values with the next available plausible value. You want to ensure uniform data handling. We talked earlier about kind of conflicting, ambiguous, and missing data. It's really important that they're handled uniformly by all reviewers and across all cases. If you have anyone other than yourself collecting data, I would certainly encourage them to ask questions. I personally like to include a box like this, questions for the study team to discuss, on each data collection form I design. This makes it really easy for me as the PI to go back and review the charts with questions, quickly identify patterns, update my data collection form if needed, or send a quick email to my study team letting them know how to handle these situations that are arising in real time as opposed to waiting until the end of the study. Lastly, when you're setting up your data dictionary and you're entering things into REDCap or into Excel, just save your own sanity and code your variables in a way that will allow for statistical analysis. Everybody has their own system, whatever it is, stick with it and be consistent. In general, I recommend categories instead of free text. For example, we have seen race can be recorded as Black, African American, BL, AA, but in reality, all those are going to be the one category when you do your analysis. Be consistent with the way you code things. So my personal convention is to use 0 for no and 1 for yes. Some people prefer 1 for no and 2 for yes. That's certainly not my preference, but whatever your system is, use it and use it across every variable in your database. It's also really important to differentiate data that are not present from data that are missing. So here's an example of a database that I received. They asked me to help with the analysis, and I got this. And the problem here I think is probably obvious. Over 75% of the data appear to be missing. So from this database, I can't tell whether the blank cells mean the condition was not present, in which case I would typically designate it with a 0, or whether the chart simply contained insufficient data to determine whether the condition was present, or whether the reviewer maybe just hadn't completed this part of the chart review yet. So again, really important to have a way to differentiate what is not present versus what's missing versus what you just haven't gotten to yet. And I mentioned this before, but once again, address missing and conflicting data. Several ways to do this. The first, and probably the most common, is to delete records with missing data from the analysis. And this is maybe acceptable if the amount of missing data is small. It may, however, introduce bias, particularly if the data were not missing at random. Sensitivity analyses are another option. In this approach, the data are analyzed several times, each time with different assumptions about the missing data. And this really allows readers to understand the potential extremes in the results. Finally, multiple imputation is a more advanced statistical analysis, or technique, I should say. The details are really beyond the scope of this seminar, but the concept is that it allows you to replace missing values with reasonable replacements based on known values. Unless you have strong statistics training, I would definitely recommend working with a statistician to perform multiple imputation techniques. So if you're lucky, you won't be doing all the data abstraction yourself, and you'll have some people to help you. If possible, you want to blind your abstractors to the goal of the study. If this is not possible, assign different abstractors to review different sets of variables. For example, maybe the first abstractor reviews the predictor variables, and then the second reviewer abstracts the outcome variables. If you have groups of patients who are going to be compared, you can also blind the abstractor to the group of to the group assignments. For example, we were doing a pre-post study before and after an intervention, but we didn't tell the abstractor that we were dividing the study population into pre-post cohorts and comparing them. We kind of let the abstractor think it was being treated as one cohort. You also really want to train your abstractors carefully. So you have this beautiful data collection form, you've created it, you've developed it carefully, you've pilot tested it, and it makes sense to you. But you really want to go through it with your reviewer in detail. Don't just email it to them and say, okay, here you go collect data. Really sit down, thoroughly review the data collection form and the variable definitions, specify where in the chart to find specific information, particularly when the abstractor needs to look in multiple places to find the same piece of information. And then really tailor that training to the abstractor's background and level of medical knowledge. The training I do with a resident or even a junior faculty member is very different than the training that I would do with a first-year medical student. In automated chart review, I mentioned that you'll want to review representative charts and outliers to validate the data that you are given. And then in manual chart review, you'll typically want to formally measure inter-rater agreement when you have 2 or more raters. While many approaches exist, the most common is the kappa statistic. So this really measures agreement between relators between reviewers beyond what is expected by chance alone. For example, if 2 raters find that 80% of patients have a certain characteristic, their agreement by chance alone, 0.8 times 0.8, would be 64%. The formula for calculating a kappa statistic is shown here. It's percent observed agreement minus percent expected agreement divided by 1 minus expected agreement. In general, we want a kappa statistic that's above 0.6, which is generally accepted to represent good to excellent agreement between raters. On the flip side, a kappa statistic of less than 0.4 is generally considered to reflect fair to poor agreement. We try to avoid this. If you do find yourself in this situation, you may want to exclude that variable from analyses or retrain your abstractors to achieve better agreement, depending on your study and your situation. So in conclusion, chart review studies have many, many benefits, but they are also prone to bias and to error. So we really need to make sure that we follow all the steps we just discussed to make our chart reviews as robust as possible. We also really want to thoroughly and transparently report our chart review methods to give ourselves credit, the credit that's due when we use the good methods we just talked about. For additional information, I highly recommend you review the Strobe statement, Strengthening the Reporting of Observational Studies in Epidemiology, and follow their recommendations for reporting your study. Another excellent resource is the article that I showed the retrospectoscope figure from by our colleagues, Drs. Kaji, Schreiger, and Green, published in Annals of Emergency Medicine in 2014. I appreciate your time. I'm happy to answer any questions you might have. My email address is here. Please feel free to reach out if you have any questions about the talk.
Okay, thank you, Dr. Mumma, for this very informative presentation. And thank you to everyone watching this presentation for the SAEM Research Learning Series. Have a great day.